Thank you very much indeed. I think building off what Dr. Brundtland said, universal health coverage at its core is really about extending services, quality services to everyone. But I think, in my view, until now, we focused very much upon the more overt barriers to accessing health services, such as financial barriers. And I think, Abina was describing some of the other barriers that exist, particularly for marginalized individuals, in terms of being treated with respect and with dignity. And I think that because health systems, they're made up of institutions, but it's people who inhabit those institutions. It's health workers, managers of healthcare facilities, clients. And so people take their own values, their prejudices, their trust or lack of trust into the health system with them and their sense of social hierarchy. And I think you see that playing out. There's a sort of big debate at the moment about respectful maternity care. And there was a review done recently which looked at the degree to which the literature around respectful maternity care. And that review found that women in childbirth were commonly discriminated against on the basis of race and ethnicity, and that migrants and refugees were particularly disrespected, and that it was also worse for adolescents and for the poor. And what I found particularly striking about the review was that this wasn't just in low-income countries. These studies were done amongst Somali refugees in Canada. They were done amongst the Roma in the Balkans. So the evidence was coming from really all over the place about the kind of discrimination that people, marginalized people, experience when they enter the health system. So I think there's a growing momentum to do something about this, and I think you see the White Ribbon Alliance campaign to end disrespectful and abusive maternity services. And there's also a lot of talk about people-centered health services and WHO's recent strategy on integrated and people-centered health services. So I think that there's a sense of the direction that we need to move in, but one of the things that we're really struggling with right now is how to distill that agenda into more actionable strategies that we can take forward. And so I wanted to put sort of 3 ideas out there in response to your question, Maitri. And the first one is really around reorienting the health workforce. I think that it's critical that we think more about how we select health workers, how we train the health workforce, and how we motivate them to behave in ways that we really want to see. And just to touch upon those briefly, I think we know that people who come from rural communities or who come from ethnic minorities are much more likely to be inclined to go back and to serve those communities. So I think we need to look at how we're selecting people for training. I think we also need to look at how we train health workers. What are the kind of ethics training that we provide to health workers? To what extent does their medical education give them the opportunity to interact with different types of clients, so that they get past seeing people as stereotypes, but really begin to see people as, in the diversity that they are. And then finally, in terms of how we motivate them, I think that it's really challenging. How do you ensure that the health workers, often working under difficult conditions with low pay, come into the job and feel that they want to treat people with the respect that they're due? And I think it's particularly challenging because health workers themselves are often in a somewhat disrespected position. Their pay may come late, they're working under difficult conditions, and their views may not be taken account of in terms of policy. So I think we need to approach that in a very holistic way in terms of thinking about how do we better integrate health workers into policy and decision making, and also treat them with more respect. So that was my sort of first idea about reorienting the health workforce. The second action area, which has already come up actually in terms of the comments that Professor Amartya Sen made earlier about the systems of public discussion, I think he called them. So I was sort of framing it in terms of social accountability. I think that there's been quite a lot of typically relatively small-scale studies recently looking at ways to strengthen the accountability of people who work in health systems to communities. And by and large, they seem to suggest that there's a lot of potential for mechanisms that can strengthen accountability, such as community scorecards or village health committees or local assemblies. And I think that there's a lot of promise there in terms of these mechanisms. And it also seems that they can be relatively inclusive, that they can involve more marginalized populations. But it seems to me that the real advantage is that they bring together communities and providers, and they help initiate a discussion between those two groups. And unless there is a conversation, I think, between the communities and the providers, we're never really going to change things. I think the real challenges, though, in terms of moving forward with strengthening social accountability, relate in part to the need, how do we scale this up effectively, and how do we sustain and institutionalize these mechanisms? But also, the evidence seems to suggest that it can't only be bottom-up. It can't only be the demand coming from the bottom. There also has to be leadership from the top. There has to be accountability coming top-down at the same time. Then third and finally, and I was delighted to hear Dr. Brundtland talk so much about the importance of multi-sectoral action. I think that one of the big challenges in many health systems is that there are so many silos in health systems. There are silos between different disease programs. There are silos between government, the private sector, for-profit, not-for-profit. And I think there's also silos across sectors between health, education, housing, social protection. So, and often there's strong resistance from the individuals who work in those silos to working across them. But I think that we know that for the most marginalized members of the community, we really do need to have collaboration across those silos in order to meet their needs. For example, I think that many marginalized populations, whether we're talking about the elderly or the disabled, often have multiple health conditions at once. So we need to work collaboratively, but we also need to be able to link them to other sectors to meet their needs, whether we're talking about housing or welfare payments or nutritional supplements. And then finally, and I think Abina mentioned this, we know that people who face stigma and discrimination in the public sector often go to the private sector to seek healthcare services. And they may not receive good quality of care there, but they're often treated with more respect and dignity than they may expect to receive in the government sector. And I think that government doesn't always take seriously its responsibilities to ensure quality in the private sector, to work across sectors. So I think one of the big issues for me is how we can engender more collaborative governance for health in the future. Thank you.
Fantastic.